You're listening to Heart Conversations, an unscripted discussion on today's hottest topics in interventional cardiology, with your host, Dejan Milasinovic. This podcast is brought to you by PCR.
Hello, everyone. It is a great pleasure to see you for the last time this year. This will be the last episode of 2025, PCR Heart Conversations. My friend and a colleague from Barcelona today is Salvatore Brugaletta, an interventional cardiologist at Hospital Clinic Barcelona. And also an editor-in-chief of PCR Online. The topic that we have chosen today for this edition of Heart Conversations is basically reflecting on the past year of 2025, what was new in interventional cardiology and what is coming next year. Of course, you can follow us live on PCR Online, Facebook, X, and also other social networks, and you will have the opportunity to listen to this as a podcast version later on demand as well. You will also be able to see the videos on demand. Salvatore, very nice to see you. How was this year for you, the year of 2025? What is the highlight, the interventional highlight for you this year?
Yes, thanks, Dejan, first of all, for inviting me to this conversation, and good morning, everyone. So to me, this year has been rich of many trials that we have been seeing during all the years in the major cardiology congress. I think that we have trial about TAVI, we have trial about calcium treatment. We have also trials about drug-coated balloon. I guess that it has been a very rich year for drug-coated balloon. And then, we have trial about the left appendage closure as well. And I think we have a lot of material, to discuss. And what was also important is that, many of these trials have not been published because we will be maybe seeing trial that has been presented but not published yet. That is also, an interesting feature, at least to say, because usually we have trial together with the main publication, but this year, we had trial without the main publication, so we may discuss about them, but we don't know, all the specific details.
So what we are going to be doing today is that we are going to be discussing trials that were presented at major conferences. Some of them were simultaneously published, some others have not been published yet. So the 4 topics that we've selected for you this year is the emergence of drug-coated balloons as an important part of everyday practice, the tools for calcium management, the closure of the left atrium appendage, and 4th, TAVI in low-risk patients. I think we can maybe start with the drug-coated balloons. That is the first of those topics that we wanted to discuss. And I think what's really new is that at the TCT this year, we had the publication of the Solution de Novo trial. And this was a trial which showed that the sirolimus-eluting solution balloon was non-inferior to drug-eluting stents in a trial which included a population of patients with both large and small vessels. Why is this significant? Historically, drug-coated balloons have been used mainly for either in-stent restenosis or small vessels. Now, in the last years, we have had several trials which tried to explore its use in de novo vessels with larger and larger diameters. Basket Small 2 trial from 2018 basically showed that a DCB was non-inferior to DES in vessels up to 3 millimeters in diameter. Then the REC Cage Free trial, which was a Chinese trial from last year, 2024, basically did show a non-inferiority in an overall population, but there was an inferior results of DCB to DES in large vessels above 3 millimeters. So this might have been a warning sign. And then this year, Solution de Novo, which also included small and large vessels, did not show, basically showed a non-inferiority. Now, what was different in all these trials? There are, of course, many nuances, but one of the things which is also important to mention and to discuss is that all these three trials basically used different devices. So different drug-coated balloons with different mechanisms of elution of the drug and the different coating of the drug onto the balloon. So the basket small used one version of the paclitaxel-coated balloon. The rect cage free used another version of the paclitaxel-coated balloon, and solution de novo used the sirolimus eluting balloon. Now the question is, are we now heading towards a new era of coronary interventions where drug-eluting balloons will replace stents, or will it be more on the complementary side? And that is the first question to you, Salvatore. How do you weigh in on this evidence that we have had so far on this topic?
Yeah, so this is, to me, a very difficult question, no? But, I mean, if you ask me if drug-coated balloons will replace drug-coating stent, I don't think so. That is the issue, and I don't think that was maybe the intention of all this trial and also of the solution. So I think that the main objective of having a drug-coated balloon is just to complement to what we have already in the shield, so drug-eluting stent, together with a new option that maybe is better in specific scenario in specific patients. In the same way, for example, as years ago, so we had the BRS, and we are still working, on the BRS. So we now have a drug-eluting stent, which may be good as drug-eluting stent, or maybe better in some specific subset. For example, if we talk about the solution, so the solution was non-inferior, but it was not actually comparing, two different devices. So what was comparing two different strategy. So one side was the full metallic strategy with the drug-eluting stent. In the other side, so there was a sort of mixed strategy. So having first the predilatation, and then so we have a good predilatation with less than 30% of residual stenosis. Then so the operator was proceeding to drug-eluting balloon. Otherwise, so he was putting a drug-eluting stent. So that is the normal flow of a trial, which is not comparing one device versus the other, but two different strategies. And what the solution says is that if you use this let's say hybrid strategy or bio-PCI strategy, so in terms of the target visual failure, so there is no inferior. So we are not going to talk about the non-inferiority margin, etc. And then so every time that you do a non-inferiority trial, so you say, okay, that is the non-inferiority that we may accept, in change of having something better, and something better will come later at 5 years with the superiority. So if it will be met, so of these hybrid strategies compared to the normal strategy that we use in our lab. And then, so what I found, interesting to me is the data about the target vessel revascularization. Because it is true that when we talk about the primary endpoint target vessel failure, so we don't see any difference. But when we look specifically to the target vessel revascularization, actually, so to me there is a difference in sense that when you use drug-eluting balloon strategy, so you may get some more target vessel revascularization as compared to drug-eluting stent. Unfortunately, we don't have much more data about that, so we don't know, even if the P value is significant or not, or if, for example, this is specific of a specific vessel like a small vessel or large vessel, and then so we needed, to wait when the trial will be published. But to me, it's interesting because up to 2025 we have been talking a lot about drug-eluting balloon, but so far, so until the solution, so there were some trials, but the solution, we may say that is the one of the trial which may mark the difference from now to the future.
So yeah, so I think I agree with what you said, and there are at least 3 points which may sort of wrap up that discussion, that brief discussion that we've had on the new evidence on DCB. So first of all, the drug-eluting balloons seem to fill a clinical need. So we all practicing interventionalists feel that metallic stents may sometimes be avoided, whether because of anti-thrombotics or because of a specific lesion subsets. Second, as you said, solution de novo is, let's say, the last of the 3 randomized trials that we introduced, but probably the largest one, and the one that showed us that there is an overall combined non-inferiority in both small and large vessels. However, and that is the third point, we need to understand the results in some more detail. And as you said, the trial was presented at the TCT, but the full text article has not yet been published. And it would be very nice for us, and we eagerly await it, to analyze some of the lesion subsets which are important, look at the comparison and the stratification of small and large vessels, and then make some more conclusions for the practice. But it seems that the drug-eluting balloons are here to stay. To which extent, for which lesions, and for which patients, I guess there are disagreements among colleagues in as much to how much of it will be used. But I think that there seems to be an agreement that they are very useful and are here to stay. And I guess that more evidence will be needed going forward to understand their specific role in our everyday practice. We would like to go to the second topic, which we said is a series of randomized trials on the management of severely calcified lesions. So what are the trials? What is the evidence that you found to be updating our everyday knowledge and, let's say, informing the ongoing practice which we already have in this field?
Yeah, so in 2025, so we actually had 3 trials about calcium treatment, which are the roller coaster, the shortcut, and the Victory. So it is interesting that all the 3 trials has as a primary endpoint the stent expansion that was calculated by IVUS or OCT, but actually the way to get there was different. In the roller coaster, so there were, if I'm correct, almost 170 patients randomized 1-1-1. 2 different devices like rotational atherectomy versus IVUS versus laser. So in the end of the day, there was no difference in terms of stent expansion, but it was interesting actually to see that many times, so there was a need for a second device. So meaning that you start with the rotational atherectomy because that is the randomization, but then you need, for example, IVL, or you need laser, or the other way around. So then we have the shortcut. Again, so here the comparison was between cutting balloon and IVL. So there was no difference again in terms of primary endpoint stent expansion that was calculated by IVUS. But what was interesting to me was the data about the fact that so the randomization was stratified by rotational atherectomy. And if you look, at the overall difference, you don't see any difference indeed between cutting and IVL. But so if you look specifically at those patients who had a prior rotational atherectomy, then a lack of difference persists. But if you look at those patients who did not have a prior rotational atherectomy, then you see actually the difference, that IVL is better than cutting balloon. That is something, to take in mind, because, we mix, and we may talk later, a different device, and that is, an important point. And last but not least, so there was the Victory trial, which was comparing in this case, so IVL versus the super high pressure balloon. In this case, so the stent expansion was evaluated by OCT. There was no difference in terms of this primary endpoint, but here is important to remark that the size of the balloon, either the high pressure IVL, was made according to the external elastic membrane measured by EC imaging.
That's very interesting. So to me, the common denominator of all these trials is twofold. First, the primary endpoint seems to revolve around the stent expansion. So the calcium trials seem not to have a clinical endpoint in 2025, but are rather concentrating and focusing on the immediate result in terms of stent expansion. So it could be that in the future, we think about the calcium management in a more long-term perspective, and not necessarily that is tied to the stent expansion. In the previous segment, we talked about drug-eluting balloons. Now imagine that treating a calcium with a lot of modification and then perhaps using a balloon, that going forward, different endpoints might be needed. That is the first observation. And the second observation is that what these trials seem to be pointing to, and what I think aligns well with our practice, is that the multi-device strategy is very often a reality. So in a single patient with calcified disease, you may very often need more than just one device. None of these trials convincingly told us that there is a single device we can use for a severely calcified lesion. And I think one of the reasons is that there are different types of calcium. And in a single patient, even in a single lesion, which is diffuse, you may have in a single segment of a coronary artery, which is severely calcified, you may have different types of calcium. Nodules, you can have deep or superficial calcium, you can have a large MLA or decent MLA or a very small MLA to start with, which can benefit from rotational atherectomy and so on. So what is your take on that? I think that those device trials may perhaps be better seen as strategy trials and collectively telling us that there is not a single device we can use, but that there is a portfolio of devices we need for a single patient very often.
Yeah, I totally agree with your point, Dejan, because to me, it does make sense, to compare different devices, but what is important, what is the fil rouge, so through all this trial is the use of imaging. So at the end of the day, so what we want to achieve is the stent expansion, which in the end is a surrogate endpoint, because of course, it's difficult to have a clinical endpoint, because otherwise you need thousands of patients, so that is, not feasible. But the use of imaging is important because it allows you, to have a plan. So to select first your first device, then to evaluate in the midway that you are doing your PCI. So if the first device work or not, and then so you may do, for example, stent implantation, or maybe you switch to a second device for optimizing better the lesion preparation, which in the end is the most important feature for your plan for your PCI in calcified lesion. Because if you don't prepare well the lesion, so you are going to implant a stent which will be underexpanded. And only imaging can give you the answer. So to me, the fil rouge, as I said, through this trial is the use of imaging. So I will be pleased, if everyone will use imaging in such complex situation, not only at the beginning but or at the end, but also in the middle. So when they are, preparing the lesion, just to be sure that the lesion is well prepared.
Yeah, I think, and at the beginning of this conversation, we said it's about what was new in this year in terms of new trials, but also it's what's coming. We want to speak about what's coming in all these topics. And for DEBs, for the drug-eluting balloons, we alluded to what are some open issues. And here I would say there are at least 2 points which are of interest. And the first one, as you said, is that the intracoronary imaging and the use of it will help us guide our procedure. However, there are open questions. For example, what is the appropriate measure of lesion preparation that will facilitate good stent expansion and overall good long-term outcomes? We do not really know decisively how to quantify the optimal lesion preparation in these lesions. What is the number of fractures? How deep the fractures of calcium should be? That is at least one of the research questions which remains open. And then the second one is, which device for which type of the lesion? And maybe for the type of the calcium. And maybe you will have very dense and deep calciums, which are also very thick, which may necessitate more than one device, which may need a combination of, for example, a combination of a cutting and the IVL. So those, for me, are open questions going forward. We go now to the third segment, and I would like to ask you again to give us a brief recap. When we were preparing this episode, and roughly speaking about what were the new things, this was the biggest unknown, at least to me. And I think that this segment of left atrium appendage occlusion is maybe somewhere where we need to learn the most going forward. But please give us a brief recap of what is it that we learned this year, and then we may discuss it further.
Yeah, so in the left appendage closure, so that is a very, interesting field, because so we start, from the option that actually is not from this year, but from last year, 2024, which you may remember, so was a trial involving more than 1,600 patients, so relatively young, so with a mean age of 60, more or less. And these patients, all of them received atrial fibrillation ablation, together with the left appendage closure versus anticoagulation. So the trial demonstrated there was less bleeding events with the left appendage closure, as expected, comparable rates of death, stroke, and rate of stroke. We may discuss later, about the limitation of this trial, but anyhow, so this was actually the trial that we were coming from 2024 up to 2025. And then, so there was the trial presented at the American Heart, so at the end of this year, so it was actually 1 month ago. It was quite disrupting, and I'm sorry, to say that this trial was not published because I want actually to see this trial published with all the specific details.
So you're very right. You're very right.
Yes.
Yeah,
yes. So what actually I get is some information. So this trial was randomized in a little bit more than 900 patients with other fibrillation. We may say that these patients, randomized in this trial, were patients with with the indication of others in real practice, because they were with the age of 79, more or less. So I would say older than the one including the option, with a CHA2DS2-VASc more than 2 and a NAS bleed more than 3. So I would say that these patients were, at least from the baseline clinical characteristics, a little bit worse than the one in the option. So patients were randomized 1-1 to left appendage closure versus optimal anticoagulation therapy. And the trial was designed for superiority, for non-inferiority, but non-inferiority was not only not met, but was even a signal, so towards a higher risk of cardiovascular death and also bleeding, which to me is surprising, in those patients randomized to left appendage closure versus anticoagulation. So, of course, this trial is not published, so we don't know, all these details. I know that other trials also will be coming. So, but to me, I was quite surprised, not because I'm a believer of the left appendage closure, but I think it's good that this trial, or at least, is aware to all the public, because we need to understand who is the patient who can benefit the most from this procedure, instead of giving, this option to everyone, maybe.
Yeah, I think, as you said, having a full text article is always helpful when we are analyzing it, but we wanted to keep it as updated as possible, so we make a topic out of it, for sure. One of the things which I noticed is that in the option trial, the procedural bleeding was not included in the primary endpoint, whereas it was a part of the primary endpoint in the closure AF trial. This, of course, makes a difference, because you will have some procedural bleeding whenever you do an invasive strategy. What is important for the patients, of course, is how detrimental that bleeding is as compared to the bleeding you will eventually get, to some extent, from oral anticoagulants down the road and over years of receiving them for AF. So to me, it boils down to two questions. With closure AF, to my humble understanding, there was multiple devices used in that trial over a span of years, which means that some updated or upgraded devices have been used as well, but first generation devices too. So the question is, do you think that with the improvement of technology and technique, the results of the LAA occlusion may improve? Or do you think that the patient selection will be decisive going from here?
Yeah, I think it is maybe a matter of all these, different characteristics. So from the point of view of the device, so it could be, some improvement, but I will not say that actually devices are much more different today as, for example, 6 years ago, because more or less, the device is the same. So same concept is something, to fulfill, this left appendage closure. So I will say that from the device point of view, so is few, to gain. From the point of view of the procedure itself, of course, as more procedure you do, as better you are, and that should be for sure a learning curve. Although, this has been excluded from the option if you look at the supplementary material, and specifically looking at the closure AF. So this actually trial was done in very few centers, very expert, in this kind of procedure. So I will say that maybe, so there could be something, but it will be open to new centers that are actually not, in this trial. And third point is about the patient's characteristics. So that to me is the most important point, because so in the option, actually the patient was not so with such disease, for example, in the closure AF. So we may say that maybe in closure AF, the patient were with a so bad clinical profile that maybe so whatever kind of option you take, so you don't take, you don't have any advantage, because at the end of the day you may reduce bleeding, but you are not improving cardiovascular death. And then on the top of that, left appendage closure is not, well, let's say, a safe procedure in the sense that is with 0% of complication. Unfortunately, so even in experienced hands, so this kind of procedure still has some complication. And
yeah, but all of the invasive procedures have a complication. You know that. So
yes, exactly. But
it's the matter of balancing risks and benefits, I guess. And to me, what you're saying makes a lot of sense. So the patient selection, I guess, will be key there. And producing a trial which convincingly shows benefit will probably depend very much on how the patients are selected. And those two, the option and closure AF, basically had very different populations. Option was just after ablation, and then the decision between oral anticoagulation versus the invasive treatment on the occlusion of the left atrium appendage.
And then, one last point, if you're looking is maybe also the use of new oral anticoagulation. So the direct anticoagulation is maybe better than the vitamin K treatment. So at the end of the day, if you compare with the syndrome of warfarin, of course, so they could be non-inferior for sure, but when we switch to new drug, so that difference,
there is less bleeding. Yeah, of course. And the difference in bleeding will be different. Yeah, I agree. So these are all open issues. So I guess this is a segment of our discussion which will have the most updated evidence going forward. And we, of course, look forward to it and to further analyzing the place of LAA occlusion in our everyday practice. With that, we come to the last segment of today's conversation, which is about TAVI. So this year at ACC and then later at TCT, two trials, or the long-term follow-ups of two low-risk trials in TAVI have been published. And the first one was the Evolut low risk, and the second one was Partner 3 long-term. So the Evolut low risk was a 5-year follow-up, whereas Partner 3 was a 7-year follow-up. In essence, they both did not show a significant difference as compared to surgery, which is combined good news for TAVI, as there was no apparent durability issue with those two platforms or those two prostheses which were evaluated, the Evolut prosthesis and the Sapien prosthesis. Now, the question is how to analyze in, let's say, more details these two trials and whether we have seen signals which can help us improve our daily practice of TAVI. In Evolut low risk, the median age was 74. For the Partner 3, it was 73, so very similar. Now, when you think about the guidelines, the new guidelines for VHD, for variable heart disease, the new age limit is 70. So it's basically well beyond those low-risk trials that we are showing today. And that is a matter of discussion, how to accommodate that new guideline recommendation in the view of this data. Now, the primary endpoint was death or stroke for the Evolut low risk and death, stroke, or rehospitalization due to the procedure in Partner 3, and they were similar. Both trials, more or less, showed more PVL and pacemaker rates with TAVI patients, more atrial fibrillation with surgery, and better hemodynamics when it conserves the Evolut valve, the supraannular self-expanding valve, as compared with surgery. Now, the question is, what do you make out of this data, Salvatore? And how do you comment on what we could see in the Partner 3 trial? And that is the crisscross of the curves showing the benefits of TAVI within the first year, which coincides with the results of the Dedicate trial, which also basically showed even a mortality benefit for TAVI as compared with surgery within the first year. The long-term Partner 3 trial data basically show us that there is a sort of a catch-up phenomenon after that first year, where the rates for TAVI and surgery of the primary endpoint seems to be similar at 7 years, catching up after the first year, meaning that you may think about more events in the TAVI arm after the first year. So what are your thoughts on that?
Yeah, I mean, to me, so it's important, first of all, I mean, to remember why these trials were done. So these trials were done, I mean, in young, let's say, patients, just to understand, I mean, if we can go beyond the inoperable patients or patients with a high risk, so together with TAVI. And having said that, so the problem with the low risk patients was not, I mean, the question, to answer the question if TAVI works, because of course, so if we work in a worse population, it will work also in a better population. But just to understand, so about the durability of the device, because in young patients, you may think about a reoperation, a re-TAVI, or for example, a surgery later on. And what to me, I mean, is interesting and important to highlight is the fact that at the end of the day, the durability, so the same is comparable to the SAVR. So then, so a second point, I mean, these trials were powered for sample size at 1 year. Here we are talking about 7 years, although you do win ratio or other kind of statistical analysis. Anyhow, so it's difficult to say that one is superior to the other, but at least you don't see, I mean, any dangerous, let's say, signal saying that at some point it would be better to have one instead of the other because you have a lot of events on one arm as compared to the other arm. So I will say that the final message from this trial is that you may treat, I mean, let's say intermediate, let's say risk patients with good, I mean, results. So saying to the patient that if you go to surgery, you may get more of this endpoint, like for example, atrial fibrillation. If you go to TAVI, so you have a more probable leak and pacemaker rate. But in exchange, so you have, for example, a better recovery, faster recovery with TAVI as compared to SAVR. So at the end of the day, it's always a trade-off when you explain the procedure to the patient that decide with your help, but at least so there is no dangerous events on one side or the other.
Yeah, I think that's an important message. And I will just close with a short remark regarding the Evolut low risk, where they analyzed the rate of zero, none, or trace AR post-TAVI, which was by far the most frequent event. 85% did not have basically any PVL. And then 14% had mild, and less than 1% had moderate or severe. And mild PVL was not associated with mortality, which I think is an important point. And then the second point is whether pacemakers were associated with mortality. Pacemakers before TAVI, because of an indication that was independent of TAVI, were associated to the same extent with mortality as pacemakers post-TAVI. And both those groups fared worse when compared with patients which did not need pacemakers at all. So a sort of a deterioration of the conduction system independent of TAVI in those patients with aortic stenosis seemed to be associated with worse prognosis. And we may incorporate that further into our decision-making when speaking about TAVI. So to close it off, I just want to once again remind you of what we have reviewed today, and that is basically the updated evidence which was published this year in the space of drug-eluting balloons with the solution de novo trial, a landmark trial which informed our practice and brought us new evidence in this field of coronary interventions, as well as new updated evidence for the LAA occlusion. And then the ongoing practice of calcium management was, I think, well informed by smaller randomized trials indicating the need for multi-device strategies for many patients. And finally, the ongoing practice of TAVI, I think, is very well informed by what you, Salvatore, nicely summed up, a reassuring message on the durability of the currently used prosthesis for our TAVI patients. With that, any final words from you, Salvatore? How do you see this year, and what do you expect next year?
Oh, I think so. This year was quite productive. So I will expect for next year. So answer to the questions that are still, pending, as you said about the calcium. I know that there are trials evaluating not device, but for example, algorithm about calcium. And then, so what will be interesting to see in the future, I don't know, if it will be on time for the 2026, will be left appendage closure. So there are actually two trials, to my knowledge, still, ongoing. One is the champion and the other one is the Laos. So one is high risk and the other one is low risk. So we will see, how this will go for the clinical practice.
Thank you very much. To all of you, thank you for following us throughout the year. We will continue with heart-to-heart conversations in 2026 as well, with new and hot topics in interventional cardiology. Thank you to the PCR team for allowing us to do this. And as I said, happy holidays and see you in the new year. Thank you very much.
Thank you.
Bye.
Thank you very much. Bye-bye.
Thank you for listening to this heart-to-heart conversation. Find out more about upcoming dates and replays of recent conversations on pcronline.com.